Samantha. I do work in Omaha at Nebraska Medicine. I've been there about 7 years. I've been in pharmacy for 15. At Nebraska Medicine specifically, I started in our outpatient pharmacy, was there for a very brief period of time before I moved over to the specialty pharmacy. Was in specialty pharmacy for like 4 years. Under specialty, I also kind of did a minor segue into our cardiology space, working in our warfarin clinic. After our specialty pharmacy, I went to what we call like our automation room. So within the last few years, we opened a centralized services pharmacy that services all 4 of the pharmacies that we kind of operate. And the centralized services pharmacy has some additional office space, I guess you could say, some retail to hopefully kind of bring the groups of us that were spread all over the map of Omaha together in one space to kind of promote more of a team environment. So I worked in our automation room, filling prescriptions for not quite a year, and then moved to the team that I'm on now, which is our MSOT team is what we refer to it as. But it manages GLP-1 medications, our HIV channel, our HIV team. And then we're opening up into like third-party payer adherence for Medicare star ratings. Like Judy said, I was actually recommended. I work really closely with our specialty care center. I'll get into more about them. But they kind of run our entire HIV program through the university. But they see a lot of HIV patients within Omaha, and was recommended to present by one of the pharmacists that I work with really closely over there. And I think I'm just so worried about like letting her down. Lots to talk about. Hopefully gives some insight into kind of what our team has worked on developing over the course of the last 18 months. I can't take all the credit. The pharmacists and the team at SCC were extremely important in allowing me and kind of trusting me to do what I do within the pharmacy that allowed us to grow the program to what it is. I do have a couple of icebreakers just because I want to know more about everybody else. This is the first presentation I'm attending, and so I guess I didn't realize that people come from kind of like everywhere. So I want to know who's, I guess just raise your hand if you've been in pharmacy for a year or more. Everybody, cool. What about greater than 2? Yeah, 3, 4, 5, 6, 7, 8, 9, 10, wow. 11, 12, 13, 14, 15? Who are you? 16? 17, 18, 19, 20? Okay, how long?
22.
How long?
22.
Wow. How long?
22.
Yeah?
23.
23? Was there somebody more? Oh, back there, yeah.
60.
Oh, wow. Okay.
26.
26? Awesome. Okay. That's a really long time. I thought 15 was a long time. Yeah, that's a really long time. Good for you guys.
That's an hour, you know?
Yeah.
Remember old school?
Yeah, right? You did say that. Just quickly, I know there's a lot of Omaha people. I see you all. Where is everybody else from? Just quick.
Colorado.
Colorado?
Illinois.
Okay.
New York.
Oh, wow.
Kentucky.
Yeah.
The Bronx, not New York.
Okay. Like I said, it's my first conference. We had kind of like a baby kind of conference way back in the day at the School of Pharmacy in Omaha, with Judy kind of running it there as well. So I'm a little familiar with how it all goes down, but a formal conference, this is my first one. So I just kind of wanted to, and I didn't make the event last night because I was stuck in Dallas. I wanted to just kind of say hi. Okay. So my presentation kind of works on how technicians within the pharmacy space can optimize the healthcare setting for patients and the clinical staff treating the patients within the clinic space. It is. Okay. So I do have some notes, just, again, nerves. Objectives today, kind of to talk through the barriers, is what we're going to talk a lot about, the barriers to medication access for a lot of these HIV patients, and not necessarily specific to HIV, but just patients in general. When you talk about reaching patients in the Medicare space, and just knowing what their insurance looks like, a lot of those people are living strictly on their Social Security, can't afford some of those more expensive medications. And so even though my presentation is kind of geared more toward HIV patients, the information can be spread across multiple patient populations and disease states and things like that. So understanding the pharmacy technician role in kind of breaking through the barriers that patients have in accessing their medication. We'll talk a little bit about the Nebraska Medicine program, kind of how it came to be, how it's impacted our clinic, and then other opportunities that technicians could have for utilizing this in other spaces. Okay, so HIV, I know we're all technicians. It sounds like a lot of us have been in the game for a really long time, so I won't go into too much detail. Is there anybody that's like less familiar with HIV? Because if there is, I want to make sure I'm like defining certain things so that I don't cause confusion, but I also don't want to talk to you guys like you don't know what I'm talking about. Okay. If you don't know something, please let me know. Okay, so HIV is kind of unique in terms of disease state and medication, in that viral suppression, making sure that the disease remains controlled, is really around the patient's medication adherence. So other chronic diseases, when you think diabetes, when you think hypertension, cholesterol, those medications in and of themselves are really, really important. It's important that the patient take those medications, be as adherent as possible. But at the same time, if they miss however many days they decide they're not going to take it for whatever reason, it's not ultimately the end of the world. With HIV, it's a little bit different, obviously. The longer that a patient is off medication, we're talking providing the disease opportunity to basically kind of like regrow, replicate its cells again, become more active in the body. And when that happens, the risk of transmission to somebody else obviously becomes greater. At that point, then it could potentially result in a population health concern. So when it comes to HIV, viral suppression, obviously the biggest goal, and through that, making sure that the patient is staying as adherent to possible on the medication. The other issue with not being adherent to medication is that you can develop, what's the word I'm looking for?
Resistance?
Thank you so much. 22 years. 26? Way more than me. She's got it. Thank you so much. Yeah, you can develop drug resistance, which makes trying to find other treatments, even still today, it makes trying to find other treatments a little bit challenging, just because some of the medications that are available even now, you have to do blood tests for. There are certain genetic mutations, things like that, that gear medications for patients and their, success rate on that medication a little bit more. So adherence is important for a lot of reasons. Okay, so when we talk about viral suppression, the viral suppression is classified as 200 copies per milliliter of blood or less. Obviously, you're still transmissible at that level, but they consider it to be a successful suppression rate. Adherence, also equally important, as we've talked about. Adherence, we want, ideally, we consider adherence to be successful if it's at 95% or higher. With the adherence and the viral suppression, patients usually have an improved quality of life because the lower their adherence, the possibility of their immune system kind of really getting out of whack makes them more susceptible to infection risk and just problems all around, hospitalizations, things like that. And then obviously reduced transmission risk by keeping that viral load as low as possible. Barriers. So that's kind of a lot of what we're going to talk through today. What barriers do you guys see for patients in accessing any medication? Cost, yeah, big time.
The stigma of it.
Stigma, yeah.
Coverage.
Yep.
Anybody else?
Even the accessibility to it.
Yep,
Burnout from taking meds every day.
for sure. Yeah, all of those are really good. We'll actually hit on a few of them that you guys talked through. So, yeah, all things patients face when trying to access their medication, and we're kind of at the forefront to be able to help the patient overcome those barriers. So I did want to kind of talk through a case study. When I was putting this presentation together and talking with my pharmacist over in the clinic, I had kind of presented this idea about this particular patient simply because she is like the poster child for what my presentation was all about. But of course, I wanted to make sure that she was okay with it, obviously HIPAA things and such. So I won't go into a ton of detail, but I thought she was a really interesting patient to kind of bring up to talk about medication access, adherence. Like she literally just ticks every box. So we did have a patient in her 50s present to our ED in January of 2025. Learned that she found out about her HIV status when she was pregnant. Throughout her pregnancy, she was taking medication, really adherent, great. But then she discontinued her medication. If I remember correctly, she said she didn't like the way that it made her feel. So when she stopped her medication, she kind of fell out of care and just was kind of MIA for a really long time. When she came to the ED in January of 25, she had a viral load of 165,000 copies. Her CD4, which, if anybody doesn't know what that is, it's kind of the marker that indicates how strong your immune system is. And the HIV virus itself is what directly attacks the CD4 cells. So the T helper cells is kind of another name if you've heard of them that way. Her CD4, in a healthy person, we like to see it at like 400 or higher. Her CD4 was at 100. We'll talk about this later too, but technically speaking, when you hear AIDS, AIDS and HIV are not separate diseases themselves. It's just that AIDS is an advanced stage of HIV. It's the most advanced stage. Someone is diagnosed with AIDS when their CD4 is 200 or less, or they have another like opportunistic infection that kind of correlates with someone with HIV. So at this stage, she's got a CD4 of 100, a viral load of 165,000 copies. She has active tuberculosis, influenza, like she's a mess. She presented, though, just with fever, chills, body aches. In a normal setting, as a 50-something woman, you could potentially write that, especially in the middle of winter in Nebraska, you could potentially write that off as just the flu or just a cold or something completely unrelated to HIV. But it was doing kind of the regular blood work, seeing that the infection, obviously her white blood cells were high, and kind of doing a deep dive, figuring out her history, that they were able to determine that her HIV had gone untreated for so long that now she is kind of, I don't want to say on death's door, but she wasn't doing well. She was a pretty sick lady. So that's our patient. Keep her in mind because we're going to come back to her. But yeah, at this time when she came in 2025, she wasn't doing well. Okay, so social determinants of health. We touched on a lot of these. So cost a lot of the time is probably one of the biggest things that kind of prevent a patient from potentially getting their medication. They step up to the counter, their copay is $200, $300 for some time. For some people, it's $30, and even $30 is too much money. But it just kind of illustrates that there's so many things outside of a patient being motivated to take their medication that could potentially prevent them from being adherent. So cost, housing instability, health literacy, and stigma, like you had mentioned, are some things that patients face when trying to gain access. I've had patients in the past tell me that their cholesterol medication was too much to take because it was just another pill that they would have to worry about taking, or because I'll just adjust to my diet, which is also great, but we need to help you get to that point before you can just make that happen. That's not an overnight thing. So yeah, a lot of things that as technicians we see kind of at the forefront to be able to help step in and possibly make an intervention to help the patient get access to their medication. So with cost comes economic stability. So economic stability, somebody having steady employment, a steady income, offsetting, things like poverty, making sure they have stable housing, food security, things like that. When those things don't happen, patients don't have insurance, can't afford their medication without any type of coverage. Even with coverage, they potentially still can't afford those copays. Eventually, they have no medication to be able to take to stay adherent on, and end up where our patient did in the hospital. Healthcare access is sometimes another big one, especially when we're talking about HIV patients. Having access to the provider, healthcare coverage in general, their access geographically to a treating provider, and then just because of a large portion of the patient population, especially that we treat, health literacy isn't always sometimes that's the greatest. And so oftentimes it's just the patient not understanding the importance of taking their medication every day, not understanding how to be able to overcome or even communicate that there's barriers at play that they need help overcoming, that also kind of segue into non-adherence. So the impact of some of these barriers, which I think just kind of us initially going through what some of those barriers might be, we can figure out that if the patient can't afford their medication, if they don't want to take another pill, if they don't want to take it because they don't want people to know that they're taking it because there's a stigma, obviously they're going to miss their refills. For HIV specifically, they're going to have poor viral suppression because with HIV, remember that medication adherence is really, really important. Which then, as we've learned from our patient, increases healthcare utilization, more doctor's appointments, more blood checks to get that viral load back down, more hospitalizations in the event of our patient who also has poor health literacy and just didn't realize how sick she was and why she got as sick as she did. Okay, so we're coming back to our patient. She came to our ED January of 2025, just really sick. She was in the hospital for about a week. The entire week she was there, she was getting HIV medication therapy, set up and antibiotics for the flu and the TB and all those things. She was getting treated for all of it. She was set up for a return appointment to our clinic so that they could follow up, make sure she got returned to care, didn't go off her therapy again. It was a couple weeks later, she ended up back in the hospital for hyponatremia, thrombocytopenia. Like, this girl was sick. She was in the hospital for another week. I think ultimately over the course of like 6 weeks, she was in the hospital, like actually admitted into the hospital for about 3 to 4 of those weeks total, if I remember correctly. But throughout 2025, she did maintain regular clinic visits. She stayed completely adherent to her medication. She's still actively one of my patients. But a year later in 2026, as of the time that I was putting this slide together, her CD4 was well above 400, which, remember, that's kind of the marker of how well your immune system is doing. And she had an undetectable viral load, completely undetectable, which means her transmission was like nearly impossible. I think just the education from our clinic working so diligently to make sure she understood why her medication is so important and why it's important to take it every day, is hopefully what helped her stay adherent throughout this point. So how can healthcare teams help patients overcome these barriers? Healthcare in general, technicians, obviously, but there's lots of ways. There's lots of room for intervention for patients who don't have access to their medication for whatever reason. There is a multitude of people on the healthcare team, from the providers and the nurses in clinic to the pharmacists and technicians and the pharmacy that give the medication, that can step in to say, this patient is struggling in this particular area. I may be able to help. If I can't, let's connect them with someone who can. So this is our specialty care center. You'll hear me probably say SCC a lot. Our specialty care center, I kind of touched on at the beginning. This is our kind of what's referred to as our HIV clinic. They are umbrellaed under the University of Nebraska educational system. So a lot of the providers in the clinic are actually employed not by the hospital that we work with, but through the University of Nebraska education system. The SCC is conveniently located in a shared parking space with another independent pharmacy that's in town. But because it's an independent pharmacy and HIV medications are so expensive, the clinic went from referring every patient to this independent pharmacy just because of proximity and the increased likelihood that the patient would pick up their medication, to referring them all to Nebraska Medicine, because the independent pharmacy now basically can't operate continuing to fill brand name HIV medications because of the cost. Such is the life, unfortunately, of an independent pharmacy sometimes, but he's been great to work with. If he gets a prescription that he can't fill for whatever reason, he automatically forwards it to us because he knows we're going to take care of the clinic. Okay. I tried to make this slide really colorful. So in the clinic, you'll hear me talk about the clinic a lot too, because while I work within the pharmacy, a lot of what I serve is the patient by way of the clinic. So a lot of my work isn't necessarily with a pharmacist. A lot of my work is with the pharmacist in the clinic or the nurses. I talk to the nurses in the clinic every single day. Oftentimes I'll have the providers in the clinic reaching out to me directly to ask questions about potential coverage, and I'm thinking about prescribing this or this or this. Can you look at the patient's insurance really quick and tell me what my best options are? So I work more closely with the clinic and the providers within the clinic than I do probably in the actual pharmacy. So the clinic patients, they have just over 1,400 active patients. As you can see, hopefully my demographics make sense. It's pretty spread out. Like, there's not one particular population, whether it be age, gender, race, that's more affected than another. It's kind of all over the place. Maybe most surprisingly to some people is that the baby boomer generation is the most prevalently affected. Does anybody have a guess as to why?
That was pretty much the start of more or less the AIDS and the HIV era.
Yes.
Products weren't screened before then?
Yes, ma'am. So yeah, both correct. Yeah, the HIV/AIDS started, I believe, in kind of like the mid-80s. Yeah. Okay. I should know my HIV history way better than I do. Yeah, like mid-80s, really peaked early 90s, when the epidemic became a really scary situation for a lot of people. But yeah, for anybody that doesn't know, before, I believe it was 1992, blood products weren't screened. So back when I first started in pharmacy, I worked with hepatitis C. So infectious disease has kind of like always been in my technician blood. I had a patient that I was working with, though. She was an elderly lady who got hep C because she had to have a blood transfusion at the birth of one of her children. And this was obviously prior to blood products being screened for blood transmissible diseases. she contracted it because of the blood transfusion that she needed to have at childbirth. And this poor lady, it gives me chills. I will never forget this woman. She always makes me emotional too. She at the time, not only while she was working to try to fight through her Hep C and this was 15 years ago when I first started. So the treatment at the time, while it was great, it's not nearly as great as it was or as it is now. But she also was fighting cancer, and her husband also had cancer. And when she learned that she had hepatitis C, their whole world kind of shut down because they're also both battling cancer. And I remember her telling me that there's no way she's going to be able to afford this because already her husband and her are alternating who goes through chemo first so that they make sure they can afford it. Right. You see why this woman has stayed with me for so long. Ooh. Yeah. I talked to this woman, I think, every day until we were able to get her a grant to at least help secure funding for her Hep C medications so that was one barrier out of place for her and her husband. At the very least, she wouldn't have to pay for her Hep C treatment. Fast forward a few months, she's midway through her treatment. I haven't talked to her in a little while because I know I've done at that point what I can do to help her go about her day. She's having appointments. She lives in Western Nebraska. She's having appointments in Omaha, apparently and this is the story that I got later from her husband, but apparently having a really bad day. Her husband says, "Do you want to stop by the pharmacy and finally meet Samantha?" And so they went out of their way to come to the pharmacy. All of a sudden, my pharmacist is handing me a sticky note because I'm on the phone with another patient. She just puts a sticky note on my desk that says, "Older couple by the fish pond for you." Well, my in-laws are right up the road, but I don't understand why they would be coming to see me at work in the middle of the day. And so as soon as I got off the phone, I went up to the fish pond, but to get there from where my desk was, there was a pretty long hallway straight through, so I could see the couple at the end of the hallway. And without knowing, I knew instantly who she was. And before I even had a chance to "Oh my gosh, it's so nice to finally meet you," she has me wrapped in a bear hug. And then, we sat down, we chatted for a minute, and that's when her husband told me that she wasn't having a good day. They were in town to see all of her doctors, and he had made the suggestion to come and finally meet me. And that's my little story for the day. What to us is kind of like run of the mill, getting a patient a grant for a prescription that they can't afford, signing them up for a copay card for a prescription that they can't afford that gets them down to a $0 copay. It may seem like something we do every 5 seconds throughout our day, every day, but I think hopefully with the story of this particular patient, we don't always know what the patient is going through because maybe we're not talking to them every day for the ability to develop the relationship for them to share those stories. But obviously what we're doing in terms of helping remove some of these barriers for the patient makes an impact in their life. Okay, so our SCC population, not only diverse in terms of gender, race, age, things like that, but they also come from multi-payer systems. So we're not talking necessarily all privately funded insurances through an employer, because as we saw in the previous slide, a lot of our patients are of kind of either at or approaching Medicare age. But even still, Medicare comes with you need to be able to afford premiums, and that's not always a possibility. So we have a large population that do have private insurance. We've got patients that have Medicaid, Medicare. We have patients that are completely uninsured. And that's where programs like Ryan White come in. Does anybody know, or I guess is anybody unfamiliar with Ryan White? Yeah, okay. I'm really glad, actually. So Ryan White is a federally funded program for HIV patients to help provide them access to all of their health care. That could be doctor's visits, it could be dental, it's vision, and encompasses medication, but it also provides resources for housing and food. So it's outside of just healthcare in general, but it really looks at being able to provide as much as possible for patients that may not otherwise have the ability to access these things. Another really sad story. It is named the Ryan White kind of program after a young boy, don't remember the date, early 90s, I want to say, but a little boy, another situation where the blood wasn't tested. He was a hemophiliac and contracted HIV. The story behind Ryan was that there was a huge kind of debate and argument between him and his mom, who kind of fought the system to be able to allow him to go back to public school. Because at the time, they didn't know very much about HIV. They didn't know about the spread. Remember, this is early 90s, really before like the huge peak and scary situation of HIV happened. And so his early childhood, I believe he was in junior high when they found all of this out, in early high school when they were trying to get him back into public school. It was really just a fight about, from his mom, advocacy, awareness, education. But after that, the government recognized a space for the need for people with the disease, and thus came the Ryan White grant. So, it's available, like I said, at a federal level. Within the grant, though, there is what's referred to as ADOP, which is state specific. It stands for AIDS Drug. Oh, God. Assistance Program. Thank you so much, whoever whispered that. I appreciate you so much. My mind just stopped working. ADOP. That provides medication-specific access for patients umbrellaed under the Ryan White program. It is not part of the federal program, though. It's state-specific, and so each state has their own set of requirements that the patient has to meet in order for them to qualify for the drug assistance program. Within our SCC space, about 72% of our patients are enrolled in Ryan White in some capacity. For some people, they just need the vision and the dental. For some people, they need literally anything that the government is willing to help them with because they wouldn't otherwise have the ability. Of the 72%, about 16% of those patients rely solely on the drug assistance program to be able to have access to their medication. So programs like these are critical sometimes in the success rate of a patient's medication adherence. Despite these numbers, our outcomes from the clinic are tremendous. Our clinic is at a 94% viral suppression rate. So 94% of those 1,500-ish patients maintain viral suppression long-term, which is pretty great. Over at our SCC space, they have a multidisciplinary team. So I know I've talked about the the pharmacist that I work with. They have 2 pharmacists over there. They have about 5 infectious disease providers on staff. They have 2 main clinic nurses, one of which also shares the hat of clinic manager. They have social workers. They have a dermatology-specific provider that is employed within the SCC space. They have a mental health practitioner, medical case managers that are different from social workers, and that the medical case manager is the one that kind of helps them apply for all of those assistance programs, help navigate the application process that they may be otherwise unfamiliar with. If the patient says, I don't have any money for food this week, the medical case manager is the one that's able to sign off and give the patient a food voucher. They sign them up for Ubers or Lyfts to take them to and from doctor's appointments. So there's an entire gamut of people dedicated specifically in that one clinic toward providing the most comprehensive care for patients with HIV. Pretty soon there's going to be a little bubble down here that says technician. I'm working on it. Okay, so we kind of touched on this a little bit earlier, the population health approach. I know we addressed why just at an individual patient level viral suppression is important, but when you think about the number of patients that could potentially have HIV in the city, in the state, in the country, and then beyond, we want to maintain viral suppression in as many patients as possible because then we're protecting the public as a whole. By addressing those barriers, coordinating care, improving the adherence for patients, helps reduce that viral load, prevent the transmission to other people in whatever way that happens. So really, HIV adherence at a single patient level is a benefit to the entire population's health. I apparently need to speed it up. Okay, how do we execute this in daily clinical practice? So that's kind of where I came in, and where technicians in general can come in to help support, whether it be a single clinic or every patient that you service at your independent pharmacy, at the VA, where CVS, wherever it is that you, wherever you practice. Because we're the ones that see it first. The doctor just writes the Biktarvy prescription, says, okay, it's going to be at your pharmacy. What the patient and the doctor don't see is that we get an insurance rejection, that it requires a prior authorization. Then there's a matter of submitting the prior authorizations. Does anybody submit prior authorizations? Yeah, lots of us. Okay. Fortunately, for those of us at Nebraska Medicine, we have an entire team within the pharmacy dedicated to doing nothing but prior authorizations, writing appeals, helping get that grant access. So a little bit of an imposter syndrome situation happening with me because while my presentation says I don't know that, I don't. But my friends like Alicia and Jupiter, they do. Heather, she's there. So that's what they do. That screen is all about them. But then by the time they're finished, it gets to me, and then I help make sure the patient stays adherent to their medication. With that comes patient outreach. So every month, I'm following up on every single refill. Right now, I actively manage, with the help of another person who we just recently added to the team, we manage about 750 patients within the pharmacy for HIV. Which when we tried to develop the program a few years back, I wasn't part of that at the time. They were managing like 50. So yeah, we've got about 750 active HIV-only patients. That's not taking into consideration the clinic that also helps with PrEP. And the patients that we fill for PrEP meds. It doesn't take into consideration the medications that we fill for post-exposure. That's strictly our HIV population. But through that, we're checking in every single month, making sure that their refill is going through without a hitch. We usually are checking a week to 10 days prior to when we anticipate needing medication. That way, if there is all of a sudden a prior authorization need because the previous one expired, they changed therapy, insurance decided on a whim they wanted to update their formulary to now not cover the medication that this patient has been stable on for 20-something years. That's where our medication access coordinators at Nebraska Medicine come in. They help with that prior authorization. We'll check in with the patients, make sure all of a sudden they've got a copay. Hey, is this affordable for you? If not, what avenues do I have to help the patient be able to afford that? Basically, the role that I share with the other technician is ensuring that the patient's access to medication and any barriers that they may face don't stop at the pharmacy. Team effort, obviously, but that's primarily my role, is to coordinate, I guess you could say, all of the ways in which the pharmacy could not prevent, that the patient getting their medication could stop within the pharmacy. Through that, obviously, improved adherence, viral suppression. Ultimate goal. You'll hear me say it a bunch. We talked about this a lot already. In what ways can we help? By coordinating assistance. We've talked about copay cards. We've talked about third-party grants. We've talked about state and federal funded programs. So there's a lot of ways out there in which cost for HIV patients should not be a barrier. Like just hard stop. So integration into population health. This is a lot of what my team is doing and kind of what we've touched on. So our MSAT team that I said I kind of work under, our multi-step order transmittal, essentially what that means is our prescribers write the prescription in Epic, which is our EMR. It stops in a queue within the pharmacy in Epic for us to then go in and do a quick benefits investigation. Whether or not that prescription is actually coming to our pharmacy, it stops regardless. So even if the patient's moving to fill at CVS, we still have the ability to do the benefit investigation first, so that if there is a prior authorization need, if we run a test claim and see that that copay is really high, we can step in and help the patient and thereby help our clinics make sure that the patient is getting access to their medication, and that by the time they go to CVS to pick up, there's not going to be any issue. So the impact of a technician, a lot. My role specifically reduces clinical burden just because they're not having to go through all of the steps to call CVS and say, hey, can you run this claim for me? I want to know what my patient's cost is going to be. Can you make sure this patient gets signed up for a copay card? They're not taking the time to personally sign the patient up for that copay card themselves. They're not worried about how to navigate a third-party grant system because they don't need to necessarily do it every day. By us in the pharmacy, in our kind of multifaceted roles, stepping in, it gets the patient access to their medication quicker, and again, improved adherence, say it with me, viral suppression. So yeah, that's kind of what our HIV program within the pharmacy is all about. Like I said, it started about 18 months ago with a smaller patient population. And then when that other independent pharmacy kind of had to not shut down, but they kind of stopped selling those brand name HIV meds. A lot of patients right now are on Biktarvy because it's well tolerated. There's not genetic testing that needs to be done. It pretty much ticks all the boxes of what like a wonder drug could be for a disease. He was like, I can't do this. So we took on all of those patients from that independent pharmacy, which led us to our like 750 patient population that we have now. So it was in working with that independent pharmacy that allowed us to continue to help these patients access their medication, because CVS, another independent that for some reason just is unable to provide these medications now, that patient could have easily just gotten lost somewhere without ability to access their medication. If that literacy is low, they're not going to know to have to ask for help. They just, well, I can't get my meds. Like, it is what it is, and move on with their life. Okay. Adherence. So nationally, I believe suboptimal adherence is considered 90% or less. Remember, we like to see adherence rates at 95% or more. Suboptimal is 90 or maybe it's 85. 85? And then optimal, nope, I was right. Suboptimal, 90%. Optimal adherence is the 95. And nationally, the rates are at like 50-50. So if you think about that, 50% of the population of patients with HIV are at suboptimal adherence, meaning the risk of potential transmission to somebody else is greater, thus becoming a population health issue. So within the clinic, obviously, there's been prescription growth, but also there's been growth within the pharmacy that I just kind of touched on with us taking on those patients from the independent pharmacy. In our fiscal year 2025 quarter three, our adherence rate in the pharmacy for the patients that we were servicing, not necessarily specific to our SEC clinic. We do have a small handful of outside providers that send to our pharmacy as well. Our adherence rate was at 96%. Fiscal year 2026 quarter three, which is what we are currently in at our organization, our adherence rate for our patients that we service within the pharmacy is at 98%. And with taking on those patients from the independent pharmacy, that was with a 141% increase in our prescription volume. So we increased our adherence rate after more than doubling, significantly more than doubling our patient population. Okay, so kind of a summarization. We're going to talk really quick. Let's see, what's important? Okay, so with what we do in the pharmacy, kind of taking some of the administrative burden off of the clinic, it allows them to develop their program. This talks about their long-acting injection program, which has only been around for a few years. And I'll talk a little bit more about it, but it provides clinical access, less clinical access for the patient because the medication dosing, rather than taking a pill every day, they're able to get an injection either every 2 months, every 6 months. It helps increase adherence. Obviously, they have a dedicated support system within our SEC space, long-term sustained viral suppression. Technician workflow, we've talked about that. Time allocation study, we've kind of touched on everything that we do. And the pharmacy, sorry, I'm going to go through these like rapid fire now. We've touched on high administrative burden in the clinic. We've taken in the pharmacy a lot of that off of their plate, which allows them increased clinical capacity and whatever that means, whether that be to develop more programs within the HIV space or to be able to spend more time with the patients at their visits to provide more education on why taking their medication every day is so important. So the expansion of the long-acting injectable program within the clinic, 27 patients back in 2022, up to 113 patients now, going from 68 monthly injections to 515. So 650% increase from program launch. They are doing wonderful things over there. Impact of the tech integration, we've kind of talked about that. Let's see, clinical time reinvestment, we've talked about that. So a little bit of the growth of our clinic program launched back in 2012 by one pharmacist who kind of wanted to really dedicate time to maybe an underserved patient population in HIV. In 2015, they established a CPA, which allowed the pharmacist to kind of have the authority to prescribe and change and do all the things with the patient medication without necessarily having to consult the doctor first, but they do write and practice under the physician. So technically the physician is signing off on it, but it's within the CPA and kind of the trusted agreement that the pharmacists are able to do that. Prevention expansion in 2017, that's when the PrEP program started. Again, I believe by that same pharmacist initially who wanted to be able to open the space to not just HIV patients, but let's catch them before they potentially get HIV. What can we do there? And so the PrEP program started. In 2022, the primary care physicians came on board. 2024, further service growth. 2025 and on, continued patient impact. Technician roles, we've kind of talked about. So like I said, a lot of what I do in the pharmacy, sometimes my work starts before the pharmacy ever gets a prescription because the nurse is calling me, hey, can you run this test claim really quick? Just because the provider's trying to figure out what regimen to prescribe. They want to know if insurance is even going to cover it. If they do, what's the cost? Sometimes we'll initiate a prior authorization before a patient. This is more in like the long-acting injectable space. We'll start a prior authorization before there's even talk of the patient starting the injection. The patient's expressed interest, so we want to see what insurance is going to do before we set up that initial injection appointment and potential injections moving forward. If we find that the patient is going to encounter barriers throughout the process. Because while they're on their injection, keep in mind they're not on oral medication. The idea of the injection is to be able to be more convenient to the patient, less doctor's visits, same viral suppression rate. So other multidisciplinary integration, that's me. So many different ways in which a technician can benefit the entire healthcare team by coordinating everything that we do with a provider, with the insurance, with other clinical support staff, with the patient. We're able to touch so many different areas in service to the patient that oftentimes Hopefully not, but oftentimes it seems like sometimes we're overlooked in the amount of ability that we have to impact a patient's life beyond just providing their medication. Again, the ability to expand what I do into other populations, absolutely there. We talked about hypertension, diabetes, hyperlipidemia. I kind of touched on Hep C when I first started in pharmacy. Just regular adherence checks to make sure. And for me, sometimes like that's just looking at the PDMP. It's looking at our PDC data within Epic. Sometimes it's trying to figure out, okay, well, this patient's no longer filling with my pharmacy. Where did they go? And that's where the PDMP and the PDC really come in handy, because we're able to see if the doctor didn't send a new prescription, maybe another provider did, they've switched care, now filling at a new pharmacy. At least I have that reassurance knowing they didn't completely fall off the map. Okay, so takeaways. We're really, really important, guys. Medication access, driving outcomes. Obviously, we are essential. We are oftentimes, if not always, the very first person that sees that there is an issue with a patient getting their medication. And then in the grand scheme of things, especially when it comes to infectious disease, making sure that the patient can get their medication is a population health benefit. Okay. We have 2 minutes. Hopefully everybody does well. I have some questions. Okay. Minimum adherence rate needed for viral suppression is, Jacob?
95.
95. Good job. It's okay if you don't know this one. I didn't really talk about it. The metric used to evaluate medication adherence over time. Does anybody have a guess? PDC, yes, ma'am. We want to look at the proportion of days covered. That's what PDC stands for. That I didn't have time to get into because I went on with my stories. PDC, proportion of days covered, makes sure that the patient is essentially missing as few doses every day as possible. So it looks at the amount of medication the pharmacy dispensed and the time that medication should cover versus how many days the patient has between fills to know how many days they're potentially missing medication. Which step in the process is most likely to create medication delays?
Insurance verification.
Is it insurance?
Yes, 100%. And primary goal of a pop health approach to HIV care?
Isn't it to eradicate the virus?
If only.
The clinic visits.
Increase
suppression.
patients with undetectable.
Yes, ma'am. Eradicate the virus completely, ultimate goal, right? Like, that's what we want. Is it a possibility? We'll see. I know that there is a goal by 2030, to have the United States completely eradicated of HIV. I'm really, really anxious to see if that happens. Okay, and then which of the following has the biggest impact on achieving viral suppression?
Medication access.
Like, come on, guys, that's what the entire world is. Get this one right. Okay, questions. Sorry, I really flew through those last few slides.
I have a super quick question.
Yeah.
So when you talk to a patient and you find or like uncover a barrier that is outside of your scope, is there like a direct access pathway you have to refer them to somebody who can help, like a case navigator, or how do you manage that?
So yeah, sometimes like one barrier that I can think of is like, let's say one of those patients that is reliant solely on Ryan White and the AIDS Drug Assistance Program within it to be able to access their medication and their healthcare. That is something that they have to reapply for every 6 months through a local, where, like for us in Nebraska, we have the Nebraska AIDS Project. There's caseworkers at the Nebraska AIDS Project that help the patient go through all of those steps to get access to whatever it is that they need, but they do have to recertify every 6 months because they are required to meet income guidelines. That is not something that we've taken on in the pharmacy, I think only because right now we don't have the capacity to. You're aware. So at that point, I'm sending text messages through our pharmacy software to the patient. We're putting, if they have primary insurance, leaves them with a $30 copay, but then they have Ryan White that was supposed to come in and pick up that balance. We're still dispensing medication. We're not completely withholding, but providing then a little note that pops up on their paperwork that says, hey, your grant has expired, you need to call either your NAP case manager, call the Ryan White line at the clinic, something to make sure that you're getting recertified. So that's like one of the biggest things I can think of that impacts Mallory and I every day, that is unfortunately beyond the ways that we can help. We'll do as much as we can to notify the patient, but we can't help the patient through the application process. My last slide, June 27th. I only included it because it's this month, is National HIV Testing Day. It's really, really important to know your status. If you are interested in knowing the testing locations in your area, you can actually scan the little QR code, pop in your zip code, and it will tell you all the testing sites. I believe every testing site on the website is a free location, so you go get tested confidentially free.